Hello, listeners. Welcome to Views on Health. On the program tonight is Dr. Theekshana Pathirana, consultant oncological surgeon at the Apeksha Hospital in Maharagama. Welcome back to SLBC, Doctor. Pleasure to have you with us.
Thank you, Fatima. It's great to be back.
And the topic that Dr. Theekshana Pathirana is going to discuss is skin and soft tissue cancers. Without any further ado, the microphone is yours, Doctor.
Thank you, Fatima. So I thought we discussed about common cancers in our setup in Sri Lanka, but it's also good to know about some of the rare cancers. But even though it's rare, it is prevalent. We see good number of patients in Maharagama Cancer Hospital. These cancers, especially originating from the skin and also a soft tissue in our body, is grouped together, and these are generally rare cancers, but when they occur, they need sort of aggressive treatment. So I thought it's a good idea to talk about them.
When you say rare, and then of course you say that you do come across patients, so it cannot be actually eliminated in that sense. You need to focus on it, you need to pay attention to it. Now, when you say soft tissue and skin, where do you see it regularly, doctor, on a more frequent basis? Is something like that patients might present with the cancer in particular parts of the body?
So these are actually, even though we are discussing together, they are two separate entities. Skin cancers, it's quite prevalent in countries like Australia, New Zealand, in those kind of countries. The white skin is a main risk factor because of exposure to ultraviolet light. So we are protected in that sense because we have melanin in our skin, but still we are at the equator. So we have a high dose of ultraviolet light throughout the year. So if melanoma is in fact the commonest cancer, skin cancer is the commonest cancer worldwide, even though its burden in Sri Lanka is low, it is very common. So like Australia, it's a very, very common cancer. So there are different types of skin cancer like melanoma, which looks like a birthmark at the beginning. And there's another entity called squamous cell cancer and basal cell cancer. These are slow-growing cancers, but melanoma is a fast-growing, aggressive kind of cancer. I've seen even young patients in Sri Lanka who had a mole or a birthmark that sort of started changing suddenly and then abruptly grew out of proportion. So I think that knowledge to know whether this is a birthmark or this is a normal skin lesion is important.
So, doctor, if you say a mole or a birthmark, both will be on the skin for a while.
Mm-hmm.
So does this cancer erupt from that point, or does it come even otherwise, a person who doesn't have a birthmark or a mole?
Generally, they come on its own. They don't have a birthmark, and then suddenly they have a lesion that looks like a birthmark. So not all birthmarks are suspicious. Most of them are normal. But if you find a birthmark that is not symmetrical, usually a normally birthmark has on either side similar, you can divide it into two basically, but asymmetrical birthmarks with irregular borders on the sides and different colors inside the same birthmark, bleeding or it changes with time. These are suspicious features, so need to get a biopsy done and get it treated. So those are the factors that sort of increases our sort of interest and our suspicion whether this is a malignant lesion or cancer lesion. And if it's more than 6 millimeters in size, a birthmark, it's again suspicious, but provided that you didn't have it from birth. Sometimes, very rarely, people who had birthmarks, their birthmark might change, and that is also suspicious.
Doctor, if you say that it's like a birthmark, or it can be color, the color can change. So are we to assume as lay people that this will be a little darker in color, different to the color of the skin? Now, in our case, we have tan skin, we have dark skin, we have fair skin. We have a range. We are not just one color.
Yeah.
In our country and especially in our region. So, to that extent,
well,
how does it appear?
So birthmarks in whatever your skin color is usually a more pigmented lesion, darker in color. But in the same birthmark, you see reddish patches or brownish patches, different colors within the same thing is also a suspicious factor. Not that they are diagnostic, it just raises suspicion. So any color variegation inside the same birthmark, irrespective of what the color is, you might have had a little brownish freckle, a birthmark, but then it changed into a darker brown, and there's a little bit of redness in it. These are suspicious findings.
So for it to be detected, and then is it okay if a person goes to a general practitioner or another doctor, or do you think he or she should, that it will be better for him or her to see an oncologist?
Oncological surgeon, for that matter. No, I think so. Even in Australia, what happens is it's the first contact is the GP. So Australia and New Zealand are sort of countries that have developed the management very high. Most of the standards come from those countries. So GPs are quite well knowledgeable and experienced to manage it. If not, a dermatologist is another point of entry, and most of the time the patients that we get are following diagnosis who need surgical management. And I don't think you have to worry that all birthmarks need to come out and worry about that it'll turn into cancer. But very rarely it happens. But when you have a birthmark or you get a new birthmark, it's always wise to get it checked by a professional.
So once diagnosed, what is the process?
So there's a lot of detail in it. We know what kind of depth the lesion is. Initially, what might happen is somebody might take a small biopsy, a small piece of it. And then once we make the diagnosis, if it's a melanoma, we need to stage it because they have a high degree of spread compared to the other two types I mentioned before. So the other two types actually do not present with a pigmented lesion. It doesn't look like a birthmark. So these lesions, then they tend to spread to lymph nodes as well. So surgery involves doing a CT scan, seeing whether it has gone beyond the where we can see it, and if so, offering surgical treatment if it's confined, do a resection and take the lymph nodes out as well. So it's a long process, needs a lot of surgery. But I think the point is if you diagnose it early, the radicality of treatment or aggressiveness of treatment is going to be less.
So once surgery is performed, have there been cases where it has recurred?
Yes, there's that is one of the main issues, especially if it has gone beyond the confines of the lesion. Our investigations, irrespective of which country you're doing those tests, they have a rate of sort of missing. There's a chance of missing some of the lesions in distant sites. So at the time you're doing CT scan or PET CT for that matter, there's nothing else elsewhere. But then 6 months down the line, you find that it has gone into a cellular level, has gone into another place, and it starts to reveal itself. So that is why melanoma is considered as a serious condition that needs adjustment. Whereas the other two cancers, they're relatively slow growing. And this squamous cell cancer, if there's someone who has a long-standing wound, we see sometimes elderly people who have ulcers, venous, because of varicose veins, some of them get wounds and they don't heal for years. This long-standing irritation causes cancer. It's called a squamous cell cancer. So if somebody is having a non-healing wound for a few years, it's a good idea to do a biopsy from the edge, and we might find that it has turned into a cancer. But they are less aggressive compared to a melanoma.
But would there be post-surgery treatment like maybe chemotherapy?
Yes,
and any other type,
absolutely. So some of these, if they have, I'm talking about melanoma per se, if they have gone beyond the confines of the lesion, sometimes we need immunotherapy beforehand, and then operative management, surgical management, and then chemotherapy or immunotherapy to follow. So it's a long process, which is complicated depending on the presentation and the type of melanoma as well.
Back again, when you speak of a birthmark or a mole, that can be there in any part of the body. So, to that extent, are we to assume that such a cancer can be in any part of the body, not necessarily where it's visible?
Generally, they are very common in sun-exposed areas because ultraviolet light is the risk factor. But there are occasions where it's not the case, and sometimes some of them can be in the mucosa as well, which is sort of inside your mouth or even in the digestive tract. Very rarely, very, very rare. So, I mean, some of them, the thing is you can't, there's no way of protecting except using a good sunscreen with good protective factor levels. So using it, even in our setup, we are not geared and trained to do that. But if you go for a Western country, they routinely do it every time they go out of the house. They put a sun protector. So I think it's worth an investment for us, even though it's very it's less common compared to the West.
And if it does recur, is it in the same area or elsewhere on the body?
Depends. If we have surgically gotten, when we are doing an operation, we try to give negative margin, which is our edge of the operation has no cancer. If that is the case, you might not get a recurrence there. But then if it has gone into the blood vessels, you can get a recurrence somewhere else.
So can it lead to any other type of cancer as well?
You
say if it goes into the blood vessel.
It's the same cancer that is in a different location is what spread means. It doesn't turn into another one. Yeah.
Like sometime be like a liver cancer or a lung cancer. Can that happen?
Fatima, what happens in cancer spread is that if it enters the bloodstream, or it can enter the lymphatic stream. If it enters the lymphatic stream, it gives you lymph nodes. But generally, if it enters a bloodstream, it can go through blood to different organs, especially organs like the liver or the lung. It's not necessarily originating from the liver. It's a deposit from that previous skin cancer. So yes, so you can have a deposit in the liver, you can have a deposit in the lung, you can have a deposit in the brain for that matter. So that's how cancer behaves. It has the propensity to enter bloodstream and then go into distant sites. That's why it's dangerous. But not all cancers behave that way. The other two cancers do not spread that fast and that aggressively. I think we can take a time to discuss the other topic as well.
Yes, please. Yes, go ahead, doctor.
So the other one I thought was soft tissue cancer. So we have, apart from the skin, we have fat, muscle, these tendons that helps us to move our fingers, fascia, etc., and joints. So all these soft tissues can also give rise to cancer. These are called soft tissue sarcomas. It's actually, again, comparatively rare. It's about it's less than 5% of all cancers that are presenting, but it's common compared to skin cancers in Sri Lanka. So this soft tissue, if any young male or young female who have a thigh lump, new onset, non-painful most of the time, thigh lump, and it's quite large, and it's sort of growing gradually, it needs to be aggressively assessed by some specialist, preferably. The initial, the commonest sites are the thigh, inner thigh, and sometimes the back. But it can again be anywhere in the body where soft tissue is. It could originate from the muscle. We give different technical names depending on it's originating from. It could, if it's muscle, we give a different name. If it's fascia, if it's different name. So there are over 70 types of soft tissue sarcomas there. So making the diagnosis is very important. Knowing what the type of soft tissue cancer is also important. Another risk factor is that if people have had radiotherapy before, they are at slightly higher risk of getting a sarcoma. If they have lymphedema, some people have swollen legs long term because of lymphatic damage. They are at a higher risk of getting this. Apart from that, it can just happen. Very rarely it can be genetic as well. So the bottom line is if it's a youngish person, around 30, 40, 50, that age group, if you get a sudden onset lump in your buttock, thigh, back, Might not be painful, but it's growing in size, quite large. Need to assess. Even if it's not large, if you detect it, it's a good idea to get it checked urgently.
And more so because it's not painful.
It might not be painful unless it can be painful, but there is a good chance that it'll be just a lump. You might think people call it a thelgidea, like a fat containing. Some of the cancers are liposarcomas. Lipoma is a fat containing lump. Liposarcoma is fat containing lump, but it's a cancer. So sometimes, very rarely, you can get this inside the abdomen as well. So it's important to get it assessed. And in terms of assessment, it could be your GP who might be seeing. But if there's an obvious lump, get it checked by a surgeon, oncological surgeon, or a physician. It doesn't matter. What should happen is that they will initially do ultrasound scan. It'll tell us give an idea of what kind of lump it is, and then probably it'll be referred to a specialist who manages it, like an oncological surgeon or an oncologist. And what they do is do a series of imaging. So something that I need to highlight is people get really worried that, okay, I have a lump, this could be a cancer, nobody's taking it away. Doing surgery is not always the option. We need to know what we're treating, what's the best treatment, and are we taking it in total and not leaving anything behind. So for that, there is an investigative pathway, which is we do all the imaging that is necessary, and that includes a CT scan and an MRI scan. And after that, we do a needle test in that order, a biopsy test, which will tell us out of those 70 sarcoma types, which type it is, what kind of behavior it has, and what kind of treatment we can offer.
So this takes time.
It takes time. That's nerve-wracking for the patient. They know that, this could be a cancer and nobody's doing anything to operate. And unfortunately, there could be people who would say, I can take this away, I can do an operation, and do the operation. But it's not going to cure the disease. It might recur, or it might be recurring in a distant place where we can't offer anything. The problem is if you jump into surgery for a person who needs some additional treatment before surgery, once you jump into surgery, then we have to wait till the wounds clear up and heal up. So that means if there is disease left behind, it's going to grow and going to spread away as well. So my advice is, if you have a lump, get it checked early, get it checked by a person who's qualified, and go through the investigative pathway.
That is important.
That's very important.
And definitely can, I think, prevent that particular cancer from going to another part of the body, because you're going to do all the tests.
Yes.
And then you're going to attend to it, to treat it.
Exactly.
Surgical.
So back in the day, what I'm talking about a few decades ago is that offers was to sort of, if it's a limb, to get rid of the limb, which can sometimes be the case in today's world as well. But nowadays we practice more organ preserving surgery, which means we are going to, to practice that safely, we need to have all the images. Sometimes we would take a large bulk of your muscle from the leg, but preserve its function somehow. To know that we are doing safely so that we don't leave anything behind, that imaging and that information is necessary. And some people might get a bit of chemotherapy, very rarely, for certain cancers as well, beforehand.
So what is the success rate post-surgery?
It depends on how you present, what disease the patient has. The commonest site that it metastasizes most of the cancers is to go to the lungs. So chest CT scan is essential in this pathway. If they have metastasis, it might not be curative intent, but if it's not, if it's localized, if you can get negative margins, cure rates are very good. So it depends on what stage the patient presents and how successful the surgery was. And depending on that, any additional treatment will depend on that. And if it's all clear, it's a good prognosis in that sense.
So, doctor, the only sign is a lump, some sort of a growth.
Yes, most of these sarcomas present with a lump, sometimes pain, very rarely. Sometimes, if there is a nerve in the area that this lump is coming from, they might get a bit of shooting pain in that region. Generally, that's the norm.
Thank you, Doctor. So interesting having discussed melanoma and the other type of skin cancers as well as the soft tissue cancers. So time is catching up with us. What would be your parting message to our listeners?
So we all worry about breast cancer, oral cancer, colon cancer. But remember, your skin, what's exposed to most of the carcinogens outside, and your soft tissue can also give rise to cancer. If you get a lump out of the blue growing, or you get a skin lesion that is not healing up, looking abnormal, has an odd shape, just get it checked.
Thank you, Doctor. And there we end an interesting discussion with Dr. Theekshana Pathirana, consultant oncological surgeon at the Apeksha Hospital in Maharagama, for being with us on the program Views on Health and sharing his valuable insight and expertise on soft tissue and skin cancers. Thank you so much to you, Doctor.
Thank you, Fatima.
Thank you too to Damayanti Kolabage for technical assistance. I'm Fatima Razikada saying good night and looking forward to your company next Monday, same time on Views on Health.